Your A1c number has huge implications on your health. Your doctor uses A1c to diagnose you with diabetes or prediabetes, but the test can be inaccurate in many people, and there's lots of doctors who are just not aware of it. Hi, I'm Dr. Leonid Kim. I am board certified in Internal and Obesity Medicine, and in this video, I'll tell you if you're one of those people that cannot rely on their A1c, and if you are one of those people, what other tests you need to get instead, including my favorite alternative to the A1c test. I will also discuss the controversy surrounding the use of A1c in diagnosing prediabetes. Now, why is all of this important? Well, the rates of diabetes are skyrocketing in the US and worldwide. And according to the most recent estimates, 13% of US adults have diabetes, and a third of US population meet the criteria for prediabetes. And because diabetes is the leading cause of kidney failure and new cases of blindness, the United States Preventive Services Task Force changed their recommendation last year to lower the age of screening for diabetes and prediabetes from 40 to 35 in those with overweight or obesity. Now, personally, I think we as a healthcare field do not pay nearly enough attention to the devastating nature of insulin resistance in our bodies, which later manifests itself in many of the common conditions that plague us today. Conditions like heart disease, strokes, fatty liver, even dementia in many cancers. So it's extremely important to identify those at risk, and to do so, we have to use the correct diagnostic tools, which is why we need to talk about A1c. Now, A1c is a good test, but it has major limitations that are important for you to know. Let's get into it. A1c, or hemoglobin A1c, is a blood test that gives you an average of your blood sugar levels over the past few months. Now, in order for you to understand how A1c can lead you astray, it's helpful to know how it works. A1c is measured by looking at your hemoglobin, which is a protein inside your red blood cells that carries oxygen. And the test measures the percentage of the hemoglobin that is glycosylated, or has a glucose attached to it. The higher your sugar levels in your blood, the higher the percentage of hemoglobins that are coated in glucose. And that percentage of glycosylated hemoglobin is your A1c. Your A1c percentage reflects the mean blood glucose over the entire lifespan of the red blood cell, which is usually about 120 days. But it actually correlates best with the mean blood glucose over the previous 8 to 12 weeks. So even though we generalize to say A1c represents your average glucose over the past 3 months, more accurately, it describes your sugars 2 to 3 months ago. And A1c is relatively unaffected by recent fluctuations in your glucose levels, so it wouldn't reflect changes that have happened over the past month. So how do we interpret these percentages? An A1c of 6.5% or higher puts you in the diabetes range, and an A1c between 5.7 to 6.4 will put you in the prediabetes range. To put that in perspective, here's the table of A1c values and its corresponding average glucose values. So the diabetes threshold of 6.5% would mean your mean glucose average is around 140. There is some controversy about the prediabetes range of A1c, or when one is considered to have prediabetes, and I will go over that controversy later in this video. Now that we know how we arrive at your A1c number, right off the bat you can probably guess what factors can give you a false result. Anything that affects red blood cell turnover will have an impact on our A1c. So conditions like iron deficiency anemia or B12 and folate deficiency anemias will give you a falsely high A1c, meaning you may be diagnosed with diabetes without actually meeting the criteria for diabetes. These anemias are associated with a decreased red cell turnover, which means those hemoglobins are exposed to glucose for a longer period of time, resulting in higher A1c levels. Other situations in which you will see a falsely high A1c are asplenia, or absence of a normal spleen, chronic alcohol consumption, and also chronic salicylate ingestion, so usually medications like aspirin. There's also important racial and ethnic differences to be considered when interpreting one's A1c. It's usually higher in African Americans, Hispanic Americans, and Asian Americans when compared to white Americans with similar plasma glucose concentrations, with a pretty significant difference of about 0.3 to 0.4%. On the flip side, the conditions that usually underestimate your A1c, where your A1c is falsely low and it looks better than it actually is, are situations in which there's increased red cell turnover, which in turn shortens the exposure of the hemoglobin to circulating glucose in your blood. And those include conditions like thalassemias, sickle cell anemia, and splenomegaly or enlarged spleen. In addition, supplementation with vitamin E, especially if taken at least 600 milligrams per day, can also give you a falsely low A1C because vitamin E interferes with glycation or binding of glucose to hemoglobin. Of note, A1C is also not routinely used in pregnancy, as it's usually falsely low through the second trimester but may rise during the third trimester. On top of that, there are instances where your A1C can be both either falsely low or falsely high, where you just do not have any confidence regarding the results, and those include advanced kidney disease, recent blood transfusions, and vitamin C supplementation. So what do you do if you fall in one of these categories where your A1C may be falsely low or falsely high? Well, you got several options. First, if you're using the test to make the diagnosis of prediabetes or diabetes, another alternative is measuring fasting glucose or getting an oral glucose tolerance test, where the blood glucose level is measured after a glucose challenge. Another option is to use a test that measures your serum fructosamine, which measures glycated albumin, instead of measuring glycated hemoglobin like we do with A1C. Now, because the half-life of albumin is much shorter than that of a red blood cell, so about 20 days for albumin versus 120 days for a red blood cell, fructosamine only gives you a snapshot of your average glucose levels over the past 2 to 3 weeks. So it's actually a better assessment of recent changes in your glycemic control. This test also has its limitations, and those are based on conditions that affect one's albumin concentrations, like in severe liver disease or in nephrotic kidney disease. Another option that's just not commonly used is a test that measures 1,5-anhydroglucitol, commercially sold under the name of Glycamark, that can offer a glimpse of your blood glucose levels within the past 1 to 2 weeks. Lastly, my favorite alternative to A1C is using a CGM, or a continuous glucose monitor. The data from CGM is real-time and also provides information on important metrics like time in range, or the amount of time we spend in the target blood sugar range, time in hypoglycemia, or dangerous periods where our blood sugar levels are too low, and blood glucose variability. Unlike A1C, which just gives us an average of our sugar levels, CGMs can also give us data on high peak glucose levels, which are associated with increased risk of cardiovascular diseases and Alzheimer's. The downsides of using a CGM is its cost, as it can get pretty expensive if it's not covered by insurance. Now, CGMs are currently indicated for all patients with diabetes type 1, and in patients with diabetes type 2, intermittent CGM use is indicated for those who are on intensive insulin therapy, patients with hypoglycemia or low blood sugar levels, or when significant therapeutic changes are made, like initiating or increasing insulin. In fact, there's growing evidence showing the benefit using CGMs with diabetes type 2 independent of the treatment regimen. Having said all that, A1C is still considered the gold standard to monitor glycemic control in patients with diabetes. It's the most widely used clinical test to diagnose diabetes and to monitor the efficacy of treatment. In fact, FDA uses A1C as the primary endpoint for demonstration of glycemic lowering for new diabetes drugs. But it's just as important to know when your A1C is misleading, as it involves making important decisions regarding your health. Decisions like whether you have prediabetes or diabetes, or what medications you need to be on. Lastly, it's crucial we discuss the controversy surrounding the A1C cutoffs to diagnose prediabetes, as the guidelines are different depending on where you live. The CDC and the American Diabetes Association consider someone to have prediabetes once their A1C gets up to 5.7. However, the WHO does not endorse using A1C to diagnose prediabetes. Instead, they recommend using a fasting glucose or a 2-hour oral glucose tolerance test. Now, both Canada and the UK, like the US, also recommend using A1C to diagnose prediabetes. However, instead of using a cutoff of 5.7 like we do in the US, they recommend using an A1C of 6 as the cutoff. Now, who's to say who's right, or which country has the better approach? I personally favor the more aggressive approach to screen for and treat prediabetes at earlier signs of insulin resistance, like they do in the US. However, I question the use of A1C to accomplish that goal. In some ways, A1C is often inaccurate to measure the true levels of insulin resistance due to reasons we discussed in this video. And in other ways, A1C just doesn't capture enough people at risk, as it misses important metrics like glucose variability or peak glucose levels, metrics that signal insulin resistance even with a normal A1c. If you found this video helpful, subscribe and share it with others. Thanks for watching, and I'll see you in the next one.